Okay, so moving on from toxic oxygen, we're going to be talking about Clostridium and Clostridium infections. So, injecting drug users, like heroin addicts, are susceptible to Clostridial infections as a result of repeatedly breaking the skin barrier with unsanitary needles. These infections the can can occur through all injection types, so intramuscular, intravenous, and subcutaneous. The clostridial infections tend to be more dangerous than minor abscesses forming infections. Clostridia are gram-positive, so like Staphylococcus and Streptococcus. Clostridia are gram-positive anaerobic bacilli typically found in the soil and the gut. Their spores germinate in oxygen-reduced environments, and pathogenic species are capable of releasing powerful exotoxins. Upon breakage of the skin barrier through injections or shrapnel in a war zone, Clostridia spores in the soil or from lingering feces on improperly washed hands can make their way into the body and begin an infection. Infection spreads fast and results in extensive skin and muscle damage, multiple organ failure, and hypertension, which is just low blood pressure. Clinical presentation of a Clostridium infection tends to involve extensive swelling and edema, as well as erythema with a blackening center that I'm sure you can identify on this poor person's leg, with accompanying necrosis and abscesses. The immune system may also begin to destroy infected muscle cells, causing myositis. So you can see the quad tends to be a popular injecting site for heroin and steroid users. Well, steroid users, it's preferred to inject in the leg, but if they're competitive, I believe the glutes are preferred because you don't get any of this nasty looking stuff in a competition because your bum is covered up by your by your shorts. But yeah, you can see the swelling with the edema. You can see the erythema with blackening centers. And we can see the beginning of some necrosis to the left side of the leg there. So that we're going to go over 6 Clostridium species that we will need to remember. The first is Clostridium novyi, type A. They're commonly found in soil and form small, flat, translucent hemolytic colonies. Hemolytic meaning they're going to break down red blood cells in a hemolysis test. Air is toxic to colonies prior to sporulation. They are unreactive in commercial anaerobe identification kits, and they're also gram variable. Clostridium perfringens tends to contaminate humans after death, causing gangrene and decay, which you can see at the top right here. Colonies tend to be non-hemolytic or produce a narrow zone of complete hemolysis within a larger zone of partial hemolysis. They are also gram variable, but they do not produce spores like Clostridium novyi. So basically just post-mortem gangrene. I'm sure you've seen it many times. You know what gangrene is. Clostridium septicum, most commonly found isolated from the blood cultures of patients with malignancies of the colon, so colon cancer. They grow rapidly and are gram variable sporeless bacilli. Clostridium botulinum, getting its name from the fact that it causes botulism, are typically implicated in foodborne infections in cases of wound botulism. They're gram-variable spore-producing, and they are also bacilli. So, botulism infections from these injections. Clostridium tesni. The cells have a drumstick appearance with terminal round spores. Colonies produce a fine swarming growth, but they have become less common in recent decades. And then finally, Clostridium histolyticum. The first case was identified from a necrotic lesion on an injecting site of a 35-year-old female in Glasgow in the early 2000s. The sample was sent to an anaerobe reference lab and the species was identified. The species is a member of the gas gangrene group, isolated from soil, bone meal, and gelatin, and it causes very severe localized necrosis. So you can see here that's gas gangrene. This is normal postmortem gangrene breakdown of the human tissues. And this is the same as breakdown of the human tissues, but you're getting air pockets forming in between these decaying tissues as a result of these Clostridium histolyticum bacteria producing gases as they break down tissues saprotrophically. So, treating Clostridium infections is pretty simple. They can be treated with early surgical intervention if there's a lot of necrotic tissue, through drainage of infected lesions to kind of get rid of the pus so that antibiotics can effectively reach the infected region, and through antimicrobial therapies like the antibiotics penicillin, metronidazole, and clindamycin. It's difficult to distinguish a Clostridial infection from a minor infection in the early stages. Clostridium identification requires strict anaerobic techniques to isolate these oxygen-sensitive bacteria. When diagnosing a patient, remain vigilant for a patient with a clinical history of drug abuse, because Clostridial infections are fairly common in drug users. Colonies suspected of being Clostridia must be identified to a species level, usually by sending them to an anaerobe reference lab, like we mentioned happened with the Clostridium histolyticum when it was found in this 35-year-old woman in Glasgow. So that's it for Clostridial infections. Thank you.